Hello everyone and welcome back to this continuous session of the human anatomy. Yesterday we talked about head and neck and we covered the cranial nerves and cranial nerve nuclei. I hope you got the time to just went through those cranial nerve at least, because we'll be needing those cranial nuclei and cranial nerve today in neuroanatomy especially. Then we discussed about the dura mater and about the fascia, the deep cervical fascia and its extensions. Now let's continue our discussion and well, let's start with the pharynx now and followed by the larynx, and then we'll go to the triangles and the blood vessels in the neck. So let's start with the pharynx here. The pharyngeal wall. Now from inside to outside, the pharyngeal wall is made up of mucous membrane. The pharyngeal wall is made up of mucous membrane. We're going from inside to outside. Pharyngobasilar fascia. Yesterday we said pharyngobasilar fascia is one of the modification of deep cervical fascia, but we didn't talk about this pharyngobasilar fascia. So today we'll talk about this pharyngobasilar, followed by the muscle coat. Muscle coat, where we have longitudinal muscle and circular muscles. Longitudinal and circular muscle, and finally buccopharyngeal fascia. Buccopharyngeal fascia. So this is the arrangement of the layers in the pharynx from inside to outside. So from inside to outside we have mucous membrane, pharyngobasilar fascia, then we have muscle coat, and in the muscle coat we have inner longitudinal and outer circular. Pharynx is one region where we have the circular muscle present outside and longitudinal muscle inside. If you look at anywhere else in the GIT, if you take a section of esophagus or stomach or anywhere, you will see circular muscles are present inside and we have longitudinal muscle present outside, but not in case of pharynx. And then we have buccopharyngeal fascia. Now what we know about buccopharyngeal fascia is that buccopharyngeal fascia is a loose areolar tissue. That's what we said yesterday. It's a loose areolar tissue. Whereas mucous membrane, this one, pharyngobasilar fascia will form pharyngeal raphe. What is pharyngeal raphe, guys? This pharyngobasilar fascia, it is present inside all the muscles, all the circular muscle and longitudinal muscle. So it goes like this, and on the posterior aspect it will form a thickened band. This midline thickened band, which provides insertion to all constrictor muscle, is called as pharyngeal raphe. So pharyngeal raphe is a modification of pharyngobasilar fascia. We already said pharyngobasilar fascia is a modification of deep cervical fascia. So ultimately you can say pharyngeal raphe is a modification of modification. It is made up of pharyngobasilar fascia, or it is a thickening of pharyngobasilar fascia on posterior aspect. So these are the walls of the these are the layers in the wall of pharynx from inside to outside. Talking about these muscle coat, the longitudinal muscle and circular muscle. The longitudinal muscle, of pharynx are, now the longitudinal muscles, they are arising from the three different regions, one from the palatine aponeurosis, from the styloid process, and from the medial end of auditory tube, which is salpinx. So longitudinal muscles are salpingopharyngeus, the one which is arising from the medial end of auditory tube, that is salpingopharyngeus. Stylopharyngeus and palatopharyngeus. One from the palatine aponeurosis is palatopharyngeus, from the styloid process stylopharyngeus, from salpinx, that is medial end of auditory tube, that is salpingopharyngeus. So the name is telling about their origin, where they are arising from, salpinx, styloid and palate. All the longitudinal muscles of the pharynx, all longitudinal muscles of the pharynx, they are inserted, all the longitudinal muscles of the pharynx, they are inserted onto the posterior border of thyroid lamina. On the posterior border of thyroid lamina. So all these longitudinal muscles will go and they will insert onto the posterior border of thyroid lamina. That is about the longitudinal muscle. What about circular muscle? Coming to the circular muscle. The circular muscle, zoom out here. The circular muscle, we have three constrictor, that is superior constrictor, middle constrictor and inferior constrictor. Superior, middle and inferior constrictor. Inferior constrictor is having two parts. We have a part of the inferior constrictor arising from the thyroid cartilage and one from the cricoid cartilage. So we have thyropharyngeus, that is thyropharyngeus and cricopharyngeus. Thyro and cricopharyngeus, from the thyroid cartilage, oblique line of thyroid cartilage, and from cricoid cartilage, thyro and cricopharyngeus. And all the constrictor muscles, all the constrictor muscle are inserted, they are all inserted to that one modification of the pharyngobasilar fascia, and that is pharyngeal raphe. They are all inserted to the pharyngeal raphe. So pharyngeal raphe is the insertion for all the constrictor muscle, whereas posterior border of thyroid lamina is insertion for all the longitudinal muscle. And see, posterior border of thyroid lamina is the common insertion for all longitudinal muscle. It also explains you why thyroid gland moves up with the deglutition. Now when deglutition takes place, it is because of these, mainly because of the longitudinal muscle. When the longitudinal muscle will contract, they will pull the thyroid lamina because they are inserted to thyroid lamina. When thyroid is pulled up, it will pull the cricoid cartilage along with it, because cricoid is attached to thyroid, and cricoid is attached to the thyroid gland, yesterday we said, by a ligament called as ligament of Berry or suspensory ligament of Berry. So this is about the pharyngeal wall and the muscles of the pharynx. Let us talk a bit more about these constrictor muscle. In the constrictor column, as we said, we have thyro and the cricopharyngeus. Now let us talk about especially about this thyro and the cricopharyngeus. The constrictor muscles, guys, when it comes to their arrangement of the constrictor muscle, now what you see, the constrictor muscles are like this. We have, these are like disposable coffee cup. You put one inside another. There is a coffee cup here, the paper coffee cup, and then you put one inside another, and then there is another one here. So it goes like this. If this is a superior constrictor muscle, it is like this in the middle constrictor, and middle constrictor is overlapped by inferior constrictor. So you can see they are all overlapping each other. This is superior constrictor, this is middle, and this is inferior. The thing is, if this is middle constrictor, let's say this is middle constrictor here, the inferior constrictor is having two parts. We have this part of the inferior constrictor, the one which is attached to thyroid cartilage, we call it thyropharyngeus. So we have thyropharyngeus part, and then we have this cricopharyngeus part. So inferior constrictor, the inferior constrictor is having two parts, that is thyro and the cricopharyngeus. It's important to note that the thyro and the cricopharyngeus, they are both are the part of inferior constrictor only, but they do have different nerve supply. The thyropharyngeus is supplied by vago-accessory complex, that is, you can say cranial accessory nerve via vagus, whereas cricopharyngeus is supplied by recurrent laryngeal nerve, branch of vagus. So this is by vago-accessory complex, that is cranial accessory nerve via vagus, and cricopharyngeus is by recurrent laryngeal nerve. Now for any reason, if there is any neuronal incoordination between the two, if there is any neuronal incoordination between the two, now what will happen if there is neuronal incoordination? Let's say the bolus will come from above, cricopharyngeus is not opening, and thyropharyngeus is having this weak part. Now this is the weak part of the pharynx here in this region, this junction of the crico and the thyropharyngeus, the region of the junction of crico and thyropharyngeus. Now this is called as Killian's dehiscence. This is called as the Killian's dehiscence. Killian's dehiscence is the junction at the crico and the thyropharyngeus, and it is a weak part of the pharynx. So as I am saying, that if the bolus is coming from above, it's not going through the cricopharyngeus, so it will push the wall of the pharynx and will come out from the weakest part. And what is the weakest part? The weakest part is the junction of thyro and cricopharyngeus, that is Killian's dehiscence. So a neuronal incoordination between the thyro and the cricopharyngeus, because they are supplied by the different nerve, can lead to the diverticulum in the posterior wall, diverticulum in the posterior wall of the pharynx, and that is called as Zenker's diverticulum. That is Zenker's diverticulum. Zenker's diverticulum. Which wall of the pharynx the Zenker's diverticulum is present? That is posterior wall. So you cannot have it laterally, cannot have it anteriorly. Anteriorly we have cartilage, laterally we also have the cartilage. Thyroid cartilage is present around it. So the only site we can have the Zenker's diverticulum is posteriorly. Posterior part is exposed. And to be precise, it's not exactly posteriorly because we have pharyngeal raphe present in between, so you cannot go posteriorly. It is like posterolateral. So the diverticulum in the pharynx, which you can say it is on the posterior wall, where exactly posteriorly? From either side of the raphe, so either posterolateral to the right side or posterolateral to the left side. So when you say posteriorly, precisely it's posterolateral to the pharyngeal raphe. Another important thing in the pharynx from where the questions are asked is about the structures passing between the pharyngeal constrictor. Now think about constrictor is the constrictors, they have a narrow origin and they have a wider insertion. So if let's say this is pharyngeal raphe schematically, and we have the muscle originating from here. So muscle originate from some region, let's say pterygoid hamulus or pterygomandibular raphe, whatever it is, and the muscle when we go toward the pharyngeal raphe, it will span like this. It will span in this manner. So we have a wider insertion and we have a narrow origin. And that's why between all the constrictor muscle you will find a gap in between, and those gap between the constrictor muscle are providing space for the many structure to go inside. So let's talk about the structures passing between constrictors. So let us talk about the structures passing between constrictors. Now let's say if this is the base of skull here, and this is pharyngeal raphe. This is pharyngeal raphe, that common insertion. So we have this pharyngeal raphe. So that is base of skull. and this is the pharyngeal raphe. Pharyngeal raphe is somewhat like this. You are looking in this manner. So we have this pharyngeal raphe present in this manner in the coronal section, and all the constrictor muscle are inserted to this the raphe in between. So there is a raphe which will provide insertion to all constrictor muscle. So we have this. Let's say this is superior constrictor muscle here. This is middle constrictor, and this is inferior constrictor. So the three constrictor muscles which are converging toward the pharyngeal raphe. This is superior constrictor, middle constrictor, and inferior constrictor. These are the gap we are talking about. The structures passing between the gap we have between base of skull and superior constrictor, between superior and middle, between middle and inferior, and below inferior. So what are the structures passing between the base of skull and superior constrictor? The structure passing, our first is we have this auditory tube. So one we have is auditory tube passing from between the base of skull and superior constrictor. The one muscle which is arising from the auditory tube and passing through this gap. See, understand this. Auditory tube is providing attachment to many other muscles. I mean, it is providing attachment on the medial side, you can say, to the salpingopharyngeus. It also provides attachment to tensor veli palatini as well as levator veli palatini. But the question is not about the attachment of the auditory tube. The question is that what structures are passing through the gap between base of skull and superior constrictor. So out of the three muscles we talked about, the only muscle which is arising from auditory tube and passing through the gap is levator veli palatini. Levator veli palatini. So auditory tube 1, levator veli palatini 2, and then we have some arteries passing through the gap. The arteries which are passing through this gap, we have ascending palatine artery. One is ascending palatine artery. Ascending palatine artery is a branch of facial artery, which we will discuss later on today. And another branch here is palatine branch of ascending pharyngeal artery. Palatine branch of ascending pharyngeal artery. Ascending pharyngeal artery is a direct branch of external carotid. It's a medial branch of external carotid. So palatine branch of ascending pharyngeal and ascending palatine artery. These are the blood vessels which are passing through this first space, that is between the base of skull and superior constrictor. So guys, auditory tube, levator veli palatini, ascending palatine, and palatine branch of ascending pharyngeal. These are the four structures which are passing from the first gap here. Second gap is about that one muscle of pharynx which is having a different nerve supply. If you remember the muscle stylopharyngeus, the stylopharyngeus muscle along with its nerve supply. What is the nerve supplying stylopharyngeus? That is glossopharyngeal nerve. So stylopharyngeus and its nerve. Stylopharyngeus muscle along with glossopharyngeal nerve. Now these are the two structures which are passing between the superior constrictor and the middle constrictor. The stylopharyngeus and its nerve supply, that is glossopharyngeal nerve. Between middle and inferior and below inferior, when you look at these two spaces, always think of larynx. I mean, larynx, what is the landmark in the larynx? The landmark in larynx is the vocal cord. We say that structure supplying the mucosa above the vocal cord and below the vocal cord. So same way, middle and inferior constrictor, the space between these two muscles is giving passage to those structures which are supplying the larynx above the vocal cord. Now yesterday we talked about the nerves, and we said that's vagus nerve which is supplying the larynx. Which branch of vagus is supplying above the vocal cord? It was internal laryngeal nerve, and below the vocal cord it was the recurrent laryngeal nerve. So guys, we have internal laryngeal nerve going inside along with the branch of superior thyroid artery which supplies the larynx above the vocal cord. So one nerve and one artery. The nerve is superior laryngeal nerve and artery is superior laryngeal nerve, and precisely which branch of superior laryngeal nerve I should say? The branch of superior laryngeal nerve, that is internal laryngeal. The superior laryngeal nerve, which branch? Superior laryngeal nerve is having two branches, internal and external laryngeal. It's the internal laryngeal nerve which is going through this gap along with superior laryngeal artery, which is a branch of superior thyroid artery. Superior laryngeal artery, which is a branch of superior thyroid artery. These are the two things which are supplying the mucosa of the larynx above the vocal cord. And remember, these are the two structures which are also piercing the thyrohyoid membrane. These are the two structures which will go inside, pierce the thyrohyoid membrane. So these are the same structures which pierce thyrohyoid membrane. They pierce the thyrohyoid membrane. Below inferior constrictor, we have the nerve which is supplying the mucosa of the larynx below vocal cord, and the artery supplying it below the vocal cord. So the nerve is a recurrent laryngeal nerve. It goes like this, and artery is inferior laryngeal artery. So we have a recurrent laryngeal nerve and inferior laryngeal artery. Inferior laryngeal artery is a branch of inferior thyroid. See, it's easy to remember. Superior thyroid artery gives superior laryngeal, inferior thyroid artery gives inferior laryngeal, and then recurrent laryngeal nerve, which you know is passing, is supplying the vocal, the mucosa below the vocal cord and most of the muscles of larynx. Now, they will not ask this question that what is passing below the inferior constrictor. The question is like that, what are the structures passing in the tracheoesophageal groove? These two structures, when they go up, they pass between the trachea and esophagus. So the question basically stands like the structures present in tracheoesophageal groove, and these are the two structures in tracheoesophageal. So remember, if the question says the structures below the inferior constrictor, or they say what is present in the tracheoesophageal groove, they are asking the same thing. The structure in tracheoesophageal groove. Tracheoesophageal groove. So this is 1, 2, 3, 4. These are the 4 gaps we can see here, and the structures passing through these gaps to go inside and supply the larynx and other structures. Now, they can ask this question that what is the structure passing between base of skull and superior constrictor. There is another way of asking the same question. Guys, in this region, we do not have a muscle, but we have a mucous membrane. Plus, we have the fascia, that is pharyngobasilar fascia. Now, in this region, above the superior constrictor and between the base of skull, now look at this, the region which I am pointing here. In this region, there is no muscle, but we have pharyngobasilar fascia here, and this is called as sinus of Morgagni. And this region is called as the sinus of Morgagni. Sinus of Morgagni, where there is no muscle in that region, only pharyngobasilar fascia. Only pharyngobasilar fascia. So the another way of asking the same question is, either they will say what are the structures between base of skull and superior constrictor, or they may ask like what are the structures passing between from the sinus of Morgagni. And mind, this is sinus of Morgagni. In the diaphragm we have foramen of Morgagni. This is sinus of Morgagni. So this is about the structures passing between the constrictor muscles. One important topic, you will find a lot of questions asked from this. So when you think of the first space, it is about auditory tube and related structures. I mean, at least remind you of the levator veli pelletini. The second gap is about the odd muscle of the pharynx, that is stylopharyngeus with its different nerve supply, glossopharyngeal nerve. And space between middle and inferior and below inferior is all about larynx. Structure supplying above the vocal cord, structure supplying below the vocal cord to the larynx. So this is all about larynx here. Moving on, coming to the next topic, that is larynx. from the anatomical point of view, the more important one. The questions are more frequently asked on the muscles of the larynx and the interior of the larynx. So let's talk about the larynx. First of all, the skeletal framework. The skeletal framework of the larynx. Guys, larynx is having this cartilage framework, which is having some paired and unpaired muscles. Paired and unpaired cartilages. The paired cartilages of larynx, as we know, are arytenoids, corniculate, cuneiforms. Whereas unpaired cartilage, the midline cartilages are thyroid, cricoid and epiglottis. So we have arytenoid, corniculate and cuneiform, then we have thyroid, cricoid and epiglottis. These are the unpaired cartilages. Out of all these cartilages, first thing we need to know is that how many cartilages are hyaline cartilages and which one are elastic cartilages. Guys, a thyroid cartilage is hyaline, cricoid cartilage is also hyaline, and you can divide arytenoid in two parts. We can say apex and base. The base, which is having the muscular process, so base is also hyaline cartilage. So please note that thyroid, cricoid and base of arytenoid, these are hyaline cartilages. And the tendency, what is the tendency of hyaline cartilage? If hyaline cartilage is not articular or present anywhere else, now the tendency is to ossify and become a bone. And that's why thyroid cartilage and cricoid cartilage, along with the base of arytenoid, they will convert into bone after the age of 20-21 max. So thyroid, cricoid and base of arytenoid are hyaline cartilages, whereas apex of arytenoid, corniculate, cuneiform and epiglottis, they are considered as elastic cartilages. Apex of arytenoid, corniculate, cuneiform and epiglottis, these are elastic cartilages. But if the question is asked specifically on the epiglottis, guys, epiglottis is not only elastic, it is one cartilage which is fibroelastic. It is a fibroelastic cartilage, the epiglottis. Epiglottis, it has to move in the closing and the opening of the laryngeal inlet, so it has to bend backward and forward. So we need a strength, we need elasticity as well. So it is fibroelastic, which is providing its strength and elasticity both. So epiglottis is fibroelastic. This is about the skeletal framework. We have 3 paired cartilages, we have 3 unpaired cartilages, which makes it total 9. So there are total 9 cartilages that we have in 3 paired and 3 unpaired. Now let's talk about the interior of larynx. Let's see what is there in the inside larynx. What about the mucosa, how it is folded, and what are the different ligaments which are formed by the membranes. So let us now talk about the interior of larynx. Now talking about the interior of larynx, first of all we need to know about the 2 important membranes. Thickening of these 2 important membranes will form the 2 ligaments, the false vocal cord and the true vocal cord. Now there is a membrane which extends from above downwards. We are talking about the interior. As I said, if this is, let's say this is the membrane here and this is the lower thickened part of that membrane. So first What membrane is this? This membrane is called as quadrangular membrane. This is called as quadrangular membrane. So there's a membrane coming from above downward. These are two membranes coming like this. We have quadrangular membrane, and the lower thickened part of this quadrangular membrane will form a ligament. So you can see this lower thickened part is there, and this lower thickened part is forming a ligament, and this ligament is called as vestibular ligament. So lower thickened part of quadrangular membrane forms vestibular ligament, which we also refer as false vocal cord. Whereas this membrane, which is coming from cricoid cartilage, now let's say if this is a cricoid cartilage, there is a section of the cricoid cartilage here. This is called as cricovocal membrane. This is cricovocal membrane. Upper thickened part of cricovocal membrane is called as vocal ligaments. Upper thickened part is vocal ligament, which we also refer as true vocal cord. So quadrangular membrane forms vestibular ligament, cricovocal membrane forms the vocal ligament. And now let me cover it with the mucous membrane. Now this is the what you call, it's a framework here made up of membrane and ligaments. Now let's say if this is the mucous membrane inside. Now this mucous membrane will run like this. So this is the mucous membrane present inside. And forming this fold here, this fold is called as airy epiglottic fold. This is airy epiglottic fold. Now when this mucous membrane goes inside and it comes this interior of the larynx, now this is mucous membrane here, the interior of the larynx, now you can divide it in two parts. This is called as supraglottic part. This is supraglottic part, which is also referred as vestibule. And this here is the infraglottic part. So we have supraglottic and the infraglottic part. That's how we divide the interior of larynx. Similarly, the space between the false vocal cord and true vocal cord. Now this space between the false vocal cord is called as rima vestibuli, and this one here is rima glottidis. Rima vestibuli, the space between the two vestibular ligament or false vocal cord, and the space between the two true vocal cords is called as rima glottidis. Please note rima vestibuli and rima glottidis. Now this blind sac that you see on the side of the larynx, this is called as the sinus of the larynx. This is called as sinus of the larynx. And this same sinus of the larynx, guys, this sinus of the larynx will go, and if let's say the section is from the posterior side, you are seeing it from the posterior, so coronal section and you are seeing it from posterior side. This sinus of the larynx will go forward and upward. So anterior and upward extension of sinus of larynx will form this blind sac called as saccule of the larynx. So saccule of the larynx will be like this. Saccule of larynx, please note it is the anterior and upward extension. It is the anterior and upward extension of sinus of larynx. So it goes forwards and upward, and that blind sac here is called as the saccule of the larynx. What about the importance of saccule of the larynx? What is the importance of this blind sac we have here, saccule of the larynx? For that, first of all, we need to know what is the lining epithelium. The lining epithelium for the larynx is respiratory epithelium. That's ciliated columnar epithelium we have. So the lining epithelium for larynx is ciliated columnar, that is respiratory epithelium, except at two places. Now what I am saying is lining epithelium for larynx is respiratory epithelium, that is ciliated columnar. ciliated columna, except 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 at these two places. Now, except at what two places? See, where we have more friction, the lining epithelium will not be ciliated columnar, it will be stratified columnar, stratified squamous epithelium. Now, if you look at the vocal cord, now this region of the vocal cord here, this will be subjected to a lot of friction, isn't it? The vocal cords will be subjected to a lot of friction, so the lining epithelium on the vocal cord will be stratified squamous. Plus, even the upper border and the anterior surface of epiglottis, the portion of epiglottis which is facing toward the tongue. In the oral cavity, everything is covered with the stratified squamous epithelium, and so is that portion of the epiglottis which is facing toward the oral cavity. So, except vocal cords and anterior surface and upper border, anterior surface and upper border of epiglottis, the mucous membrane which is covering the anterior surface and upper border of epiglottis, and these two regions, the lining epithelium will be the one which is required in those regions where friction is more, and that is stratified squamous epithelium, obviously non-keratinized. So, stratified squamous epithelium in the vocal cord and the anterior surface and upper border of epiglottis. So, rest everywhere it is ciliated columnar, but except the vocal cord and the upper and the anterior border and the surface of epiglottis, we have stratified squamous. Now, the thing is, vocal cords, they do have a stratified squamous epithelium because they are subjected to a lot of friction, but they do not have mucous gland. Now, vocal cords, please note, vocal cords are devoid of mucous gland. Now, if vocal cords are devoid of mucous gland, if there is no mucous gland on the vocal cord, but they need mucus, I mean, wherever we have more friction, we need more mucus over there for lubrication. So, if there is no mucous membrane, mucosal gland present in the region of the vocal cord, where the mucus will come from? The mucus will come from the saccule of the larynx. The saccule of the larynx is the house for all the mucous glands, and that's why saccule of the larynx is also called as the oil cane of the larynx. Please note that the vocal cords are devoid of mucous glands, and they receive mucus from the saccule of the larynx. See, along with gravity only the mucus will come and it will run over the vocal cord, and that's why the saccule of the larynx are also referred as oil cane of the larynx. They are having all those mucous glands inside, so it is also referred as oil cane of larynx. Well, this is about the interior of larynx. Let's come to the muscles which are producing movement inside the larynx. So, muscles of the larynx, one very important topic here. The muscles of the larynx, first of all, we must know that the muscles of the larynx are divided in three groups. The muscles which are closing and opening the inlet of the larynx. And how will you close and open the inlet of larynx? By moving the epiglottis. So, the muscle for the movement of epiglottis, that is closing of inlet and opening of inlet of larynx. This is one group. Then another group of muscle which is responsible for abduction and adduction of the vocal cord, that is changing the rima glottidis, abduction and adduction. So, second group of muscle is the muscle controlling the rima glottidis, and third group of muscle, the muscle which controls the tension in vocal cord, either they tense or they relax the vocal cord. So, let's talk about the muscles of the larynx in these three different groups, starting with muscles controlling the inlet of larynx. So, first we have muscles controlling inlet of larynx. Muscles controlling the inlet of larynx. How inlet of larynx is controlled? That is by moving the epiglottis. Now, if this is epiglottis here, let's say this is epiglottis, I'm just writing E here, that is epiglottis, and there somewhere we have these arytenoid cartilages. The arytenoid cartilage. Epiglottis is in front and arytenoid are behind. Epiglottis is in front, that is at the angle of the thyroid cartilage, and arytenoid cartilages are behind, resting on the cricoid cartilage. So between this epiglottis and arytenoid we need a muscle. Now the muscles which are running between the arytenoid cartilage, we call them interarytenoids, and there are two types of interarytenoids. One is transverse arytenoid like this. This is a transverse arytenoid, and the one which goes from the muscular process of one to the apex of another, this is oblique arytenoid. This muscle here is transverse arytenoid. This is transverse arytenoid muscle, and this here is oblique arytenoid. As you can see, they are running obliquely, so we call them oblique arytenoid. Now oblique arytenoid muscle are spanning from the muscular process of one arytenoid to the apex of another arytenoid, and we have a morphological extension of the same muscle which actually reaches the lateral border of epiglottis. So this oblique arytenoid muscle, we have an extension of this oblique arytenoid muscle within the aryepiglottic fold, and this morphological extension of oblique arytenoid is called as aryepiglotticus. From arytenoid to epiglottis we call it aryepiglotticus. Aryepiglotticus. So please remember that aryepiglotticus is a morphological extension of oblique arytenoid only. This is one question which is, it can be one prospective new question, that aryepiglotticus is a morphological extension of oblique arytenoid, and when this aryepiglotticus will contract, what will happen? It will pull the epiglottis backwards, and when it pulls the epiglottis backwards, that will close the inlet of the larynx. So this is the muscle for closing of inlet of larynx. This is the muscle for closing of inlet of larynx. So the first muscle we talked about is aryepiglotticus for the closing of inlet of larynx, and this muscle is a continuation or the extension of oblique arytenoid. We close the inlet of larynx, now we need to open it. How will you open the inlet of larynx? Now we need to pull this epiglottis backward, forward again. And how will you pull it? The muscle which is coming from the cartilage outside. The cartilage outside is thyroid cartilage. So from the thyroid to the epiglottis we have muscle which will pull it back, and that is called as thyroepiglotticus. Thyroepiglotticus. This is the muscle for the opening of inlet of larynx. For the opening of inlet of larynx. So guys, this is the first group we are talking about. Aryepiglotticus muscle, which is an extension of oblique arytenoid, is for the closing of inlet, and thyroepiglotticus from the thyroid cartilage to epiglottis will open the inlet of larynx. So this was the first group which controls the inlet of larynx, the muscles controlling inlet of larynx. Coming on to the next one, the second group we talked about are the muscles which will control the rima glottidis, the muscle which is responsible for abduction and adduction of vocal cords. So second group is the muscles controlling the rima glottidis. Muscles controlling rima glottidis. And what are the muscles controlling rima glottidis? First of all, we should know what exactly is rima glottidis. Now rima glottidis is not only the space between the two vocal cords, it is also the space between the two cartilage. If you take a transverse section, guys, if you take a transverse section, let's say this is thyroid cartilage, and there we have the two arytenoids, and let's say these are the vocal cords. Mind you, this is the transverse section. This is vocal cord. So what I am saying is that rima glottidis is not only this space. This is rima glottidis and this is a space between the two vocal cords, so we call it intermembranous part. This is intermembranous part of rima glottidis, and this here is intercartilaginous part of rima glottidis. So we have two part of rima glottidis, that is intermembranous and intercartilaginous. So space between the two vocal cord and the space between the two cartilage, that is rima glottidis. So let's talk about the muscles which are controlling the rima glottidis. So there's two muscle here which is for the abduction and adduction. Now once again, let's say this is the thyroid cartilage. Now the muscle which will move the arytenoid cartilage is like this. If this is the axis here, and the arytenoid cartilages are moved in this manner. This muscle here which is producing the abduction, as you can see, the muscle is abducting the vocal cord, it is increasing the rima glottidis here. This muscle is going from the, is attached to the arytenoid cartilage and attached to the posterior surface of cricoid cartilage. So the muscle is called as posterior cricoarytenoid. This is called as posterior cricoarytenoid muscle, and posterior cricoarytenoid muscle, remember, it is the only abductor. It is the only abductor of the vocal cord. No other muscle is doing the abduction, rest other muscles are for tensioning or adduction, but the only abductor of vocal cord is posterior cricoarytenoid muscle. And because it is the only abductor, it is the only muscle which keeps the airway patent, that's why it is also referred as safety muscle of the larynx. This is also referred as safety muscle of the larynx. On the other hand, there is another set of muscle here. Now once again, this is thyroid cartilage. Let's say the muscle which will move the arytenoid cartilage like this. Once again, there is the axis. This muscle here which moves the arytenoid cartilage like this, bringing both the vocal cords close to each other. You can see this was the abductor, this was doing the abduction. Posterior cricoarytenoid is the only abductor, but this muscle here is doing the adduction, and the muscle is attached to the lateral side of cricoid cartilage, so the name is lateral cricoarytenoid. It is lateral cricoarytenoid muscle, to the lateral part of the cricoid cartilage, so we have lateral cricoarytenoid muscle. The lateral cricoarytenoid muscle is for the adduction. It is for the adduction of vocal cord. But if you look carefully, guys, it is doing the adduction of the vocal cords. It is doing the adduction of the only intermembranous part of the rima glottidis. It is only closing the intermembranous part. Intercartilaginous part is still open. You can still see the space between the two cartilage. So it is for the adduction of intermembranous part. Adduction of intermembranous part. And when we use this muscle, when both the vocal cords will come close to each other, but still there is a space between the two cartilage, that means the air can still come out from the posterior part of the laryngeal rima glottidis here, and this is in case of whispering. So if the question says what is the muscle of whispering, the muscle of whispering is the lateral cricoarytenoid. When we close the rima glottidis anteriorly, but posteriorly there is a space between the two cartilage which you can still see, and that is possible by the movement of bilateral cricoarytenoid muscle. It brings both the vocal cord close to each other, and still there is a space between the two cartilage, that is called as lateral cricoarytenoid, doing the adduction of only intermembranous part, and that we use in case of whispering. When we whisper, we use this muscle. So this was the second group which is controlling the rima glottidis, the muscle for the abduction and the muscle for the adduction. This muscle is making the pyriform shape of the rima glottidis. The abductor of the larynx, that is posterior cricoretinoid. They can also ask this question like, what is a muscle which presume the rima glottidis as rhomboid shape or pyriform shape. So pyriform shape or the diamond shape of the rima glottidis is by the posterior cricoretinoid, and the muscle which is responsible for the adduction of intermembranous part of rima glottidis is lateral cricoretinoid, or in other words the muscle responsible for whispering, that is lateral cricoretinoid. Third and the final group, the third and the final group is the group of muscle which controls the tension in vocal cord. So what are the muscles controlling tension in vocal cord? The muscle that is doing the stretching and relaxation of the vocal cord, that is muscle controlling the tension in vocal cord. Now let's say once again, if I'm just this time I'm drawing this arytenoid cartilage in neutral position. If these are the two arytenoids here, that is vocal ligament. The muscle which is extending from the thyroid to the anterolateral surface of arytenoid. Now what muscle is this, guys? The muscle is from the thyroid to the anterolateral surface of arytenoid. The name of the muscle will be thyroarytenoid. This muscle is thyroarytenoid. This muscle is thyroarytenoid. Thyroarytenoid, from the thyroid lamina to the anterolateral surface of arytenoid. Now the modification of thyroarytenoid, or I should say the medial part of thyroarytenoid or the medial fibers of thyroarytenoid, they will converge along with the vocal cord and will get attached to the anterior 1/3 of the vocal cord. See, this is important, how exactly they are going and attaching. The extension of the thyroarytenoid muscle, the medial extension of thyroarytenoid muscle, this is called as vocalis. This muscle is called as vocalis. It is an extension of thyroarytenoid only, or these are the medial fibers of thyroarytenoid only, and this muscle is running along with the vocal cord, and in the anterior 1/3 it is actually attached with the vocal cord. Now this statement is important, it is attached to the vocal cord as well. The vocalis muscle, it is running parallel to the vocal cord in posterior 2/3. So what happens is, when this muscle will contract, the two cartilage will come close to each other, and when cartilage will come close to each other, the vocal cord will get relaxed. The vocal cords will get relaxed, but it is only the relaxation of which part? Posterior 2/3. Because the muscle is attached to the anterior 1/3 of the vocal cord, so where the muscle is attached to that portion of ligament, that portion of ligament will get tensed. So basically vocalis muscle is responsible for tension in anterior 1/3, and relaxation in posterior 2/3. Tension in anterior 1/3 and relaxation of posterior 2/3 of the vocal cords. This muscle, when it contracts, it will do the relaxation in this part, it will relax the vocal cord here, but the portion where it is attached, this portion will get tensed because the muscle is pulling it, so that portion will get tensed. So tension in anterior 1/3 and relaxation of posterior 2/3 is done by vocalis, and that's why vocalis is also referred as the modulator of the larynx. It is also referred as modulator of the larynx. One muscle doing both function, tensioning and relaxation, so it is also called as the modulator of the larynx. So tensioning and relaxation, both, the vocalis. Please also note one thing about the vocalis. I am giving this statement directly from the Gray's 41st edition, that vocalis is one muscle which is responsible for changing the pitch of voice or timbre of voice by affecting the mass of the cord. It changed the pitch of the voice by affecting the mass of the cord. If the question, see, pitch of the voice can be changed by even strap muscles. The question is that muscle changing the pitch of the voice. If I have to choose one muscle which can change the pitch of the voice from all the laryngeal muscle, the best answer would be cricothyroid. But look at the statement. The statement is changing the pitch of the voice by affecting the mass of the cord. If it says the muscle which changes the thickness of the cord or affecting the mass of the vocal cord, and that can change the pitch of voice, that the answer will be vocalis. So from the laryngeal muscle, forget about the strap muscle, from the laryngeal muscle, if the question says the muscle which can change the pitch of the voice, the best answer would be cricothyroid. But if the question says muscle changing the pitch of the voice by affecting the mass of the cord, then the answer should be vocalis. So in the muscles controlling the tension of vocal cord, one is vocalis, which is mainly for relaxation and partly for the tension, and the muscle which is purely for the tension of vocal cord, that is cricothyroid. Now if this is the cartilage here, thyroid cartilage, that is cricoid cartilage. Now this muscle here, that is cricothyroid. Yesterday we talked about the nerve supply of cricothyroid. It is the only muscle which is supplied by external laryngeal nerve. Rest all the muscles are by recurrent laryngeal nerve. So cricothyroid is the pure tensor of vocal cord. It is the pure tensor of the vocal cord. Every time this muscle will contract, it will bend the thyroid cartilage forward. So thyroid cartilage will bend forward like this. So it will bend the thyroid cartilage forward, and bending the thyroid cartilage forward means the distance between the thyroid and arytenoid will increase. Increasing the distance, that means tensioning of vocal cord. So it is the tensor of the vocal cord by bending the thyroid cartilage forwards. When the muscle contracts, it bends the thyroid cartilage forward and it tenses the vocal cord. So modulator of the larynx, or for the segmental tension of the larynx, we have vocalis, tension in anterior 1/3 and relaxation of posterior 2/3. For pure tensioning of vocal cord is by cricothyroid, and that is by supplied by external laryngeal nerve. Remember, the nerve here is external laryngeal nerve, and for rest of them the nerve is recurrent laryngeal nerve. This is about the muscles of the larynx. So we have the muscles of the larynx, which we discussed in three groups: the muscles controlling the inlet, the muscles controlling the rima glottidis, and the muscles which are controlling the tension in vocal cord. Before moving on to the next topic, let me also tell you about one more thing in larynx, and that is one important space called as pre-epiglottic space, or clinically which you refer as Boyer space. The pre-epiglottic space. The pre-epiglottic space. Now what is pre-epiglottic space? If you take a sagittal section, like this, so we have hyoid, then we have thyroid cartilage, and just behind thyroid cartilage we have epiglottis. So we have hyoid, thyroid, and behind this we have epiglottis in the mid sagittal section. So let's say if this is the section of hyoid, and that is a section of thyroid cartilage. That is thyroid cartilage. What is there between the hyoid and thyroid? What membrane was that, guys? This membrane is thyrohyoid membrane. This thyrohyoid membrane. And let's say there is epiglottis. This is epiglottis here. We are looking at into the sagittal section. This is epiglottis. I'm just writing E here. E is for epiglottis in the sagittal section. The hyoid bone is connected to the epiglottis by a ligament. This is called as hyoepiglottic ligament. and we also have a ligament present here in this part that is called as thyroepiglottic ligament. So there is hyoepiglottic and this is thyroepiglottic. So guys, hyoepiglottic ligament is forming the roof, hyoid bone, thyroid membrane and thyroid cartilage are forming the anterior wall. Thyroepiglottic ligament is forming the floor and epiglottis is forming the posterior wall. It is forming the posterior wall. This space which is trapped inside, this space here, this is called as pre-epiglottic space. This is called as pre-epiglottic space, also called as Boyer's space. Pre-epiglottic space, or also referred as Boyer's space. Pre-epiglottic space or Boyer's space. So boundaries of this pre-epiglottic space is important. Now another thing here about this pre-epiglottic space, there is a question here that supraglottic carcinoma. Now let's say we have a supraglottic carcinoma here in the larynx. So this is, let's say this is supraglottic carcinoma. The question is, can supraglottic carcinoma infiltrate inside the pre-epiglottic space? Yes or no? The supraglottic carcinoma, yes, it can infiltrate into the pre-epiglottic space. How? Not through lymphatics, but via epiglottic perforations. If you look at epiglottis, if you look at this epiglottis in the atlas, what you'll see, epiglottis, guys, if let's say this is epiglottis here, epiglottis is a perforated cartilage. Epiglottis is a perforated cartilage. If it is a perforated cartilage, that means the only thing standing between the supraglottic carcinoma and pre-epiglottic space is mucous membrane, and mucous membrane is never a barrier for any carcinoma. So please note, supraglottic carcinoma can infiltrate into the pre-epiglottic space or Boyer's space through epiglottic perforations. Supraglottic carcinoma can infiltrate into pre-epiglottic space through epiglottic perforations. Through epiglottic perforations. Through epiglottic perforation. These are all epiglottic perforations. So this is all about larynx. We don't have to talk about the nerve supply, which we already discussed in the cranial nerves. We said mucous membrane above the vocal cord is supplied by internal laryngeal nerve and below is by recurrent laryngeal nerve. And all the muscles of larynx are supplied by recurrent laryngeal nerve except one. Which one? That is cricothyroid, which is by external laryngeal nerve. This which we already discussed yesterday in the cranial nerves. So we know about the nerve supply of the muscles and the mucosa of the larynx. Moving on, now let's come to the next topic here. Now we are in position actually to talk about these triangles. Knowing the cranial nerves, knowing the pharynx and larynx will help us knowing about these triangles better. And let me tell you that when we read these triangles in first year, we found them a bit difficult, because in the first year when we read these triangles, they were in the beginning of head and neck. Posterior triangle, if I remember correctly, posterior triangle in BDC, it is probably in third or fourth chapter somewhere, and we started reading about these triangles immediately after the scalp, face and deep cervical fascia, knowing nothing about the cranial nerves, knowing nothing about the blood vessels. And that's why there are many structures which in the triangle which we just mugged it up. There are these structures which are present in the triangle, and because we know the cranial nerves now, so we can talk about these triangles more comfortably. Secondly, we only need to talk about the important aspect of the triangles. Plus, we have to take all the triangles simultaneously. Questions in the PG exams are not like, usually it's not like that what are contents of digastric triangle, what is the content of carotid triangle. The questions are usually about the continuation of structures. What structure will start from posterior triangle and go into which triangle? Then if they give a nerve, that this nerve is present in which triangle of the neck, or they will say the blood vessel, how many blood vessel, how many branches of external carotid artery is in the carotid triangle, how many are in digastric triangle. So these are the kind of questions which are asked, for which we need to know all the triangles simultaneously. We need to know all the triangles simultaneously so that we can see that what structure is starting from where and going into which. So let's look at the boundaries of the triangles first, and to look at the boundary of triangle, what we are going to draw is like this. You turn your head to one side. Now this is the upper boundary of the triangles we have here, that is base of mandible, external auditory canal, mastoid process and occipital bone. Now this is all superior boundary here. The inferior boundary is by manubrium and the clavicle, manubrium and clavicle. So superior boundary and that is inferior boundary. The superior boundary, as we said, it is by mandible, external auditory canal, mastoid process and this is occipital bone. This is mandible, external auditory canal, mastoid process and occipital bone. And let's say here we have the manubrium, this is manubrium here, and the clavicle. There we have the anterior midline and this is the posterior midline. Now you are looking at the side of the neck. This is anterior midline and that is posterior midline. The posterior midline is by this muscle, that is trapezius. I will be labeling these muscles along its length. This is trapezius. The muscle here is trapezius. The main muscle which is dividing the triangle is sternocleidomastoid. Sternocleido, this is from the sternum and clavicle, sternocleidomastoid. So this muscle here is sternocleidomastoid. So because of the sternocleidomastoid, the triangles of the neck are now divided in two parts. This is the anterior triangle we have, and there we have the posterior triangle. Now anterior and posterior triangle are further subdivided by certain muscles. Now let's say this is a hyoid bone here. If this is a hyoid bone, this muscle here is the anterior belly of digastric, and the muscle which goes behind like this is the posterior belly of digastric. I'm writing it in short here. This is anterior belly of digastric and this is posterior belly of digastric. And another muscle which is extending from hyoid bone and going to scapula, the only muscle which connects the hyoid bone to scapula, that is superior belly of omohyoid. This is superior belly of omohyoid, and we have inferior belly of omohyoid. Superior belly of omohyoid, and this is inferior belly of omohyoid. So guys, these are the muscles which are dividing the triangles. We have sternocleidomastoid, that is the main muscle which divide the triangle into anterior and posterior. There we have trapezius. Then we have further division of the anterior triangle and we have further division of posterior triangle. So sternocleidomastoid divides the triangle into anterior and posterior. Posterior triangle having these two parts. What are these two triangles? Now this triangle here is called as occipital triangle. This is occipital triangle, and this here is called as supraclavicular or subclavian triangle. Supraclavicular or subclavian, because subclavian vessels are present here, so also called as subclavian triangle. Supraclavicular or subclavian triangle. So these are the two subdivisions of the posterior triangle. Remember, it's occipital triangle, not suboccipital. Suboccipital is behind. This is occipital triangle and this is supraclavicular triangle, the two parts of posterior triangle. So that's what we said, that posterior triangle is having two further subdivisions, that is occipital and supraclavicular or subclavian triangle. whereas anterior triangle is having 4 subdivisions, or I should say precisely there are 3.5 actually. It's only half of this triangle we can see, and rest are complete triangles. We have only one submental triangle, so when you turn your head to one side you can only see half of submental. So I should say there are 3.5 triangles in the anterior. And what are those triangles? Now this one is called as carotid triangle. So one is the carotid triangle. This here is between the digastric belly, we call it digastric triangle. The triangle here is only having muscle, so we call it muscular triangle. And as I said, this is half of submental triangle. This is a submental triangle. This is half of submental triangle. Half of submental triangle. So this is about the boundaries and the division of triangles. We have occipital, supraclavicular, carotid triangle, muscular triangle, digastric triangle, and half of submental triangle when you see it from the side. Submental triangle can be seen like this. This is submental triangle. This is complete submental triangle between the two bellies of digastric. Now we'll talk about the two triangles in detail here, and something about the digastric as well. So the occipital, supraclavicular, that is posterior triangle and carotid triangle. Let's talk a bit more about these two triangles and their contents and the structures inside, and then something about the digastric triangle as well. So starting with the posterior triangle, we need not draw the same diagram again and again, so we'll be just drawing it like a triangle and talk about the structures present inside. So starting with the posterior triangle. The posterior triangle. First, roof. And as I said, we don't have to draw the same complicated diagram again and again. So let's say this is the triangle here. And we know the triangle is divided by the muscle, that is inferior belly of omohyoid. This is sternocleidomastoid, this is trapezius, there is clavicle, and the muscle which is dividing it, this is the inferior belly of omohyoid. The roof of the posterior triangle, in fact the roof of any triangle you talk about, that is made up of skin and superficial fascia first thing. So apart from the skin and superficial fascia, what is there? In the roof of posterior triangle we have 4 cutaneous nerve, and all the 4 cutaneous nerve running in different direction, and they all start from the one point which is called as nerve point. So behind the sternocleidomastoid somewhere we have a nerve which goes behind along with the sternocleidomastoid. This is called as lesser occipital nerve. Lesser occipital nerve. The nerve which ascends superficial to sternocleidomastoid and it goes and supplies the skin at the angle of the mandible. This is called as great auricular nerve. Call it great auricular nerve. Remember, great auricular nerve, guys, it is the only non-trigeminal nerve to supply the skin of the face. We supplied the skin of the face by a trigeminal nerve, ophthalmic, maxillary, mandibular. This is a non-trigeminal branch. It is coming from cervical plexus. Great auricular nerve is the only non-trigeminal nerve to supply the skin of the face in the region of this angle of mandible. So angle of mandible is supplied by the great auricular nerve, the only non-trigeminal nerve to supply the skin of the face. Another nerve from the same region which goes anteriorly, and remember when we say it goes anteriorly, that means it is also going toward which triangle? What is the triangle in this region? We have carotid triangle here. This is called as transverse cutaneous nerve of neck. Transverse cutaneous nerve of neck. And then finally we have a nerve which passes superficial to clavicle in most of the cases, and this is called as supraclavicular nerve. This is supraclavicular nerve. If you remember, yesterday we said there are two structures present in the supraclavicular space. There were two spaces, guys, present in the investing layer of deep cervical fascia. One is burn space and one was supraclavicular space. So supraclavicular space was giving passage to supraclavicular nerve, and one vein also we wrote there, and that vein was external jugular vein. So external jugular vein will also come like this and go inside to drain into the subclavian vein. So this external jugular vein is also present in the roof. External jugular vein is also present in the roof. So 4 cutaneous nerve and 1 vein. These are the things which you got to remember for the roof of the posterior triangle. The 4 nerve, lesser occipital nerve along with the sternocleidomastoid along with its posterior border. Great auricular nerve goes superficial to sternocleidomastoid, supplies the skin at the angle of mandible. The one which goes anteriorly, that's why we call it transverse. It goes into the carotid triangle also. So we call it transverse cutaneous nerve of neck. And the one which passes superficial to clavicle, in most of the cases, sometimes you find it piercing the clavicle and coming out. And the name is quite misleading, guys. The name is supraclavicular nerve because the origin is above the clavicle, but it actually supplies the skin below the clavicle. So the name is supraclavicular nerve. It comes down and supplies the skin below the clavicle. And then we have this external jugular vein. And these two structures, if you remember, external jugular vein and supraclavicular nerve, they both are present in what space? That is supraclavicular space of the investing layer of deep cervical fascia. Next is floor. Floor of posterior triangle is made up of certain muscles which are prevertebral muscles. The muscles which are forming the floor we have semispinalis capitis, splenius capitis, semispinalis capitis, splenius capitis. These are caput muscles. These are the muscles which are attached to the base of skull. Then we have this major contribution by the muscle, that is levator scapulae. Major contribution by the levator scapulae. And then we have these scalene muscles also forming, that is scalenus posterior, scalenus posterior and scalenus medius. Scalenus posterior and scalenus medius. These are the muscles which are forming the floor of the posterior triangle. Semispinalis capitis, splenius capitis, the maximum contribution is by the levator scapulae, and these two scalene muscles, scalenus posterior and scalenus medius. Now if you consider all these muscles like a tiles present in the floor, and the floor is to be covered with a carpet. And what is the carpet covering this muscle? Now all these muscles are prevertebral muscle, and the prevertebral muscles are covered with, you know, the fascia that is called as prevertebral fascia. So guys, floor is made up of all these muscles plus prevertebral fascia which is covering them all. Plus prevertebral fascia, the modification of deep cervical fascia which covers all the prevertebral muscle. So that is about the floor of posterior triangle. That was the roof. This is posterior triangle, floor, and finally contents. We just need to look at the important contents of the posterior triangle. The contents of posterior triangle are now occipital triangle. Occipital triangle is called as occipital triangle. It is related to occipital bone. It also gives passage to this artery, that is occipital artery. So one content is occipital artery. One content is occipital artery here. This is sternocleidomastoid and this is trapezius. Sternocleidomastoid and trapezius is supplied by what nerve? The nerve was spinal accessory nerve. So spinal accessory nerve is also the content. Spinal accessory nerve supplying sternocleidomastoid and trapezius are also the content. And we also have this, the nerve which are C3 and C4. The C3 and C4 division C3 and C4 divisions are also supplying the sternocleidomastoid and trapezius. Remember, spinal accessory nerve is the motor branch to the sternocleidomastoid and trapezius, whereas C3 and C4 are proprioceptive branches. They are for proprioception. These are the proprioceptive branches to sternocleidomastoid and trapezius. The important content in the supraclavicular or subclavian triangle, first of all we have trunks of brachial plexus, and we also have subclavian vessels. We call it subclavian triangle because we have subclavian vessels here, the subclavian artery and subclavian vein. So subclavian vessels are also the contents here. That's all we need to know about the important contents of the posterior triangle. The occipital artery, C3, C4 nerve which are proprioceptive to sternocleidomastoid and trapezius, spinal accessory nerve, the motor branch to sternocleido and trapezius, trunks of brachial plexus and supraclavicular triangle along with the subclavian vessels. This is about the posterior triangle. So roof, floor, content and boundaries. Coming to the next important triangle, that is carotid triangle. It's probably the most important here because carotid triangle will have the carotid vessels. So we can also talk about the branches of external carotid artery there. So now let's talk about this carotid triangle. So I'll just take out this carotid triangle and talk about the different parts of it. So just do remember, we'll only take out this triangle here, that is posterior belly of digastric, superior belly of omohyoid and sternocleidomastoid. So we'll take out this triangle and talk about the carotid. So there we go. First is the roof. I mean, we don't even have to draw this for the roof. What is the roof of posterior triangle or carotid triangle? See, roof of the carotid triangle is having one nerve which we already talked about coming from posterior triangle, that was transverse cutaneous nerve of neck. So one will be the transverse cutaneous nerve of neck. Then we have one subcutaneous muscle present here. We already know that muscle. That what is the muscle, guys? That is platysma. And what is the nerve supplying platysma? When we are talking about the facial nerve, yesterday we have 5 branches of facial nerve. Which one was supplying the platysma? The 5th one, that is cervical branch of facial nerve. So in the roof of posterior triangle, the important structures are, we have platysma, cervical branch of facial nerve, and then transverse cutaneous nerve of neck. Transverse cutaneous nerve of neck. Floor of carotid triangle is made up of 4 muscles, out of which 3 muscles are related to hyoid bone only. So the name of those muscles are hyoglossus. We'll talk about this hyoglossus in the next section. Hyoglossus, thyrohyoid, Middle constrictor, see the common thing about these three muscles is all three are related to the hyoid bone, hyoglossus, thyrohyoid. Even middle constrictor is originating from greater and lesser cornua of hyoid bone. And then we also have inferior constrictor. So these are the muscles which are forming the floor of carotid triangle, the roof and the floor. Boundary we already know. Coming to the important part, that is the contents of carotid triangle. So let's say this is the carotid triangle, as I already said. This being the sternocleidomastoid, this is posterior belly of digastric, and this is superior belly of omohyoid, that is a boundary. The contents of this triangle, or the contents of carotid triangle, first is, as the name suggests, carotid triangle. So we have common carotid artery, and this common carotid artery will divide into external carotid and internal carotid, which actually it will continue as internal carotid, and it will also give the external carotid. So first thing is, in the contents of carotid triangle we have common carotid artery, the continuation of common carotid artery, this is internal carotid, and that is external carotid artery. Common carotid artery and internal carotid artery reminds me of carotid sheath. Yesterday when we were talking about carotid sheath, we said carotid sheath is having common carotid, internal carotid. What vein was there? That is internal jugular vein. The vein inside is internal jugular vein. And what is the nerve which is trapped between the two? That is vagus nerve. So guys, vagus nerve and internal jugular vein. So common carotid artery, external carotid, internal carotid, vagus nerve and internal jugular vein. These are the contents of the carotid triangle. Apart from that, what other important structure we have? Now we have Okay, I'm going to repeat this content thing once again because I guess there was a problem with the sound or something. So I'll repeat the content of carotid triangle. As we have this common carotid artery here, the common carotid artery continues as the internal carotid. The internal carotid gives off external carotid. So common carotid, internal and external carotid all are the contents here. Along with this vein, that is internal jugular vein, which we saw yesterday in the carotid sheath, that we have internal carotid, internal jugular vein, along with the vagus nerve present in between. That is vagus nerve that you can see, which is present in between. The hypoglossal nerve, which is marching forward, and the spinal accessory nerve, which is marching backwards into the posterior triangle. So these are the contents of the carotid triangle. So we have three nerves present here, that is 10th nerve, 11th nerve and 12th nerve. Now apart from these, what are the other contents of carotid triangle? We have common carotid and internal carotid, which do not give any branch in the neck. The branches in the neck are all from external carotid artery. So let's see what are the branches of external carotid artery here that are given off in this region and are present in the carotid triangle. So let's talk about the external carotid artery. So what we are doing is we are drawing this common carotid artery, we are reducing the size of internal carotid and we are continuing with this external carotid here, so that we can talk about the branches of external carotid in detail. The first branch of external carotid artery is superior thyroid artery. This is superior thyroid artery. Now what's important for us is to note that from which triangle to which it is going. Superior thyroid artery starts from this carotid triangle, and as you can see it is going into this triangle. What is the triangle in this region, guys? There was a muscular triangle, so it also goes into the muscular triangle. A branch of external carotid artery which we can't see is actually present on the medial surface of this external carotid, and that is called as ascending pharyngeal. So I'm just drawing it for the sake of completion here. This is ascending pharyngeal. We can't see ascending pharyngeal as it is on the medial side of external carotid. So that is ascending pharyngeal. Then a branch of the external carotid artery which goes into the digastric triangle and then toward the tongue, that is lingual artery. And we also have the tortuous facial artery going toward the face. So that is lingual and that is facial. One, two, three, four. One more, and that is occipital artery. That is occipital artery. These are the 5 branches of external carotid artery which are given off inside the carotid triangle. There are we have other 3 branches as well, but if the question says what are the contents of carotid triangle, so guys, contents of carotid triangle are these: common carotid, external, internal carotid, internal jugular vein, 3 nerves, that is 9, 10 and 11 and 12, and then we have these branches of the external carotid artery given inside. The branches, that is facial, lingual, superior thyroid, ascending pharyngeal and occipital artery. To complete the external carotid artery, what other branches we have? We have another branch of this external carotid artery, and this is the branch, this is the only branch which is given off inside the digastric triangle. We call it posterior auricular artery. This is posterior auricular artery. It's the only branch of the external carotid artery which is given off in this triangle. Remember, I'm not saying that this is the only branch present in the triangle. We have facial artery, lingual artery also present in the digastric triangle, but the question is what is the branch of external carotid which is given off in the digastric triangle, and that is posterior auricular. And then we have finally the 2 terminal branches of the external carotid artery. One is the superficial temporal and one is maxillary artery. We have superficial temporal artery and we have this maxillary artery. So these are the 8 branches of external carotid artery. There are mnemonics for everything. I mean, anatomy is full of mnemonic. Like there's a mnemonic here: Sister Lucy's powdered face often attract medical student. But I don't believe too much in mnemonics because when you're done with 19 subjects, then there are so many mnemonics you have to do that at the end of the day you probably only remember the mnemonics and not the full form. So we should use the mnemonic where only at very few places where it is required, and all these branches of external carotid artery, their name is good enough to tell about that where exactly they are going, how they are located. I mean, superior thyroid artery because it supplies thyroid gland, and thyroid gland is present deep to this muscular triangle. So obviously superior thyroid artery is going from the carotid to muscular triangle. Lingual artery supplying the tongue, obviously from the carotid triangle to which one? That is digastric. Facial artery, needless to say, it is the facial artery supplying face. Ascending pharyngeal artery, it ascends along the pharyngeal wall, and when it ascends along the pharyngeal wall, it is medial to the external carotid artery, so we can't see it. Occipital artery, posterior auricular, as the name suggests, they are going backwards. One is behind the auricle and one is going to the occipital region. Maxillary and superficial temporal, the two terminal branches, and please note maxillary artery is the largest branch of external carotid. It is the largest branch of external carotid. Superior thyroid artery is the first branch. Superior thyroid artery is the first branch of external carotid. Ascending pharyngeal artery is the only medial branch. Ascending pharyngeal artery is the only medial branch, the only branch which is given off on the medial side. This is the first branch. Maxillary artery and superficial artery, the two terminal branches. Maxillary is the largest. Maxillary is the largest branch of all when you compare it with the rest of the branches of external carotid. So this was about the carotid triangle. So carotid triangle in total, these structures plus these 5 branches which are given off in the carotid triangle, including superior thyroid, ascending pharyngeal, lingual, facial and occipital artery. Now I have a question, guys. The question is facial artery. If you see, the facial artery is tortuous. Facial artery is tortuous. Why facial artery is tortuous? It is tortuous because it goes through the muscles of mastication and facial expression. So we need more length of this artery so that when you open and close your jaw, then you have the extra length of the artery which will prevent the artery from being torn. Fine, we have a facial artery which is tortuous, but the question is why facial vein is not tortuous. Now imagine the facial vein which is thinner than the artery, also going through all these muscles of facial expression and everything, but the vein is not tortuous but artery is tortuous. As a matter of fact, the vein should be tortuous because vein is thinner. The chances of the injury to vein is more than the artery, but still the artery is tortuous and not the vein. The reason is that vein and artery on the face, they are not corresponding. Artery goes anteriorly. Artery is present very close to the angle of mouth, to the ala of the nose, to the medial angle of eye, so it runs very close to all these major orifices. It runs like this. But facial vein is quite posterior to it. It is running away from the angle of mouth, away from the ala of the nose. So it is running away from these orifices. That's why it is running away from the area of maximum tension, and that's why there is no need for the tortuosity of the vein. The artery is running anteriorly and close to all these area of maximum tension, that's why it is tortuous, but the vein is running slightly posteriorly on the face and not corresponding the artery, and that's why the facial vein is not tortuous. This is about the two most important triangles, that is carotid triangle and posterior triangle. Now something about the digastric triangle. Now the important thing in digastric triangle are the relations of hyoglossus. The relations of hyoglossus. There are two muscles there. The two important muscle in the digastric triangle, hyoglossus and mylohyoid. Both these muscles are forming the floor, the mylohyoid and hyoglossus. Their relations are very important because surgical intervention to the submandibular gland, we need to deal with this hyoglossus muscle. So we should know what is superficial and what is deep to hyoglossus, and if you know the superficial and deep structures of hyoglossus, collectively they are all contents of the digastric triangle, all important major contents of anterior part of digastric triangle. So we are talking about the relations of relations of higher glosses which are invariably the contents of anterior part of digastric triangle. These are contents of anterior part of digastric triangle which we will do with the respect of relations to higher glosses. So as the name suggests guys, higher glosses. Now if this is a hyoid bone here, lesser conua and the greater conua, so this is the muscle that is higher glossus. Let's say this muscle here is the hyoglossus muscle. Hyoglossus, the reason we call it hyoglossus because it is going to the tongue. So there it is going to the tongue. So we have a tongue here, this is tongue, just writing T, that is hyoid bone and the muscle is hyoglossus. The question is about the superficial and deep relations of hyoglossus. The superficial relations of hyoglossus, we have two nerves and we have a duct in between. So the nerve we have here, one is the lingual nerve, hypoglossal nerve, and between lingual and hypoglossal nerve this duct here, that is the submandibular duct or Wharton's duct. Although lingual nerve winds below the hypoglossal nerve, I am just making it a schematic diagram, so I am not drawing it that way. So this here is lingual nerve, this is hypoglossal nerve, and this is Wharton's duct or submandibular duct. Wharton's duct or submandibular duct. These three structures are superficial to hyoglossus and you can comfortably add one more to this. Now if you remember guys, yesterday we said lingual nerve is topographically related to what ganglion? What was the ganglion to the lingual nerve? The ganglion was submandibular ganglion. That submandibular ganglion is also superficial to hyoglossus. So please remember these are the structures superficial to hyoglossus. Lingual nerve, hypoglossal nerve, between them we have a duct that is submandibular duct, and this ganglion which is topographically or morphologically related to lingual nerve, that is submandibular ganglion. Structures deep to hyoglossus. The structures deep to hyoglossus, we have this artery, that is lingual artery. We just saw the lingual artery is coming from the external carotid. So that lingual artery is deep to the hyoglossus. Along with the muscle here, that is stylopharyngeus muscle which goes deep. Stylohyoid, sorry, and the nerve. This is lingual artery. This is lingual artery. This is glossopharyngeal nerve. And glossopharyngeal nerve supplies what muscle? What was the muscle supplied by glossopharyngeal nerve? That is which pharyngeus? That is stylopharyngeus. Stylopharyngeus, along with the stylohyoid ligament as well. But stylopharyngeus muscle, glossopharyngeal nerve, the nerve supply of the stylopharyngeus, along with lingual artery, these are the structures which are deep to hyoglossus. Now these are the structures which are deep to hyoglossus. I am writing D in front of them. These are deep to hyoglossus, and all these structures are superficial to hyoglossus. So structures superficial and deep to hyoglossus, and together they are forming the contents of anterior part of digastric triangle. Lingual nerve, submandibular ganglion, submandibular duct, hypoglossal nerve, superficial. Deep may we have stylopharyngeus, glossopharyngeal nerve, and lingual artery. Actually there is one branch of lingual artery which also goes superficial. If you want to add that, there is a branch of lingual artery called as suprahyoid branch. It is also superficial. This is called as suprahyoid branch of lingual artery. Suprahyoid branch of lingual artery. This is also passing superficial to the hyoglossus. So these are the structures which are present are related to hyoglossus, very important, and they are important with respect to the relations of the hyoglossus. So all together are forming the contents of anterior part of digastric, and the relations very important, that what are the superficial and what are the deep structures to hyoglossus. Now let's take few more topics in head and neck from here and there. The important one, like let's talk about the parotid duct. They do ask question on parotid duct. Let's also talk about the facial artery and vein in bit more of detail, how the venous drainage of the face is there, and also about this one very important joint, that is TMJ, temporomandibular joint. So starting with the parotid duct or Stenson's duct first. Now parotid duct or Stenson's duct. There are three types of questions which are asked from the parotid duct. Parotid duct or Stenson's duct. If you take a transverse section TS of the parotid gland, now let's say this is the parotid gland here, in the transverse section of parotid gland, and there we have parotid duct which goes and run obliquely inside, to open in the vestibule of mouth by piercing the mucous membrane. So guys, let's say this is parotid gland here, this is, I'm just writing PG, that is parotid gland. This is parotid duct. Now when the parotid duct, parotid duct runs on this muscle here, that is masseter muscle here. Parotid duct runs superficial to masseter muscle, and once it reaches the anterior border of masseter, it goes inside and pierces certain structure to open. So first thing is that parotid duct or Stenson's duct do not pierce this muscle, it is only running superficial to this muscle, and this muscle is masseter. So it is running superficial to masseter muscle, and then it pierces three structures before it pierces the mucous membrane in that sequence, starting with buccal pad of fat. So first it pierces the buccal pad of fat, then it pierces the fascia, that is buccopharyngeal fascia, and finally it pierces the muscle, that is buccinator muscle. So the structures pierced by the parotid duct in that sequence, in the sequence we have buccal pad of fat, buccopharyngeal fascia, buccinator muscle, and finally the mucous membrane. So BBM, triple BM or B cube M. The structures pierced by the parotid duct are BBBM, that is buccal pad of fat, buccopharyngeal fascia, buccinator muscle, and mucous membrane in that sequence. So this is first question, that what are the structures pierced by the parotid duct. Another question which is asked about the parotid duct is about what level it pierces the mucous membrane. So the level it pierces the mucous membrane is different from the level it pierces the buccinator muscle, and they both are asked in the exam. It pierces the mucous membrane and it pierces the buccinator muscle at different level. So it pierces the mucous membrane at the level of opposite upper second molar, and it pierces buccinator opposite upper third molar, and they both are asked in the exam. It pierces the buccinator muscle because it is running obliquely. See, you cannot have the parotid duct running transversely. If the parotid duct runs transversely, then every time we blow our cheek, we will blow the parotid gland, because It will go along the parotid duct. The parotid duct is clamped, it is closed. Why it is closed? Because running obliquely in the buccinator muscle, and because it runs obliquely inside, that's why the level of piercing the buccinator is different from level of piercing the mucous membrane. So it pierces the buccinator at the level of upper third molar, and it pierces the mucous membrane to open in the vestibule of mouth at the level of upper second molar. So it pierces mucus and the buccinator muscle at different levels. So this was about the parotid duct and the structures pierced by the parotid duct. Let us also talk about the arteries on the face, that is facial artery, and also the venous drainage there. So let's first talk about the facial artery. So let's see the facial artery first. Now let's say this is the side of the face we are looking at. There we have the side of the face. The facial artery begins from the external carotid artery at the level of greater cornua of hyoid bone. Guys, if this is the external carotid artery, so from the external carotid artery at the level of greater cornua of hyoid bone, this is the, let's say that this level represents the greater cornua of hyoid. The greater cornua of hyoid bone. So facial artery begins at the greater cornua of the hyoid bone. It goes deep to the ramus of mandible, and then it pierces the deep cervical fascia, runs onto the face very close to the angle of mouth, to the ala of the nose and medial angle of eye. This is the cervical course of the facial artery, and this is facial course of facial artery. Now what we know here is that face is devoid of deep fascia, but neck was having the deep cervical fascia. So there should be a level where the facial artery pierces the deep fascia to come out. And what is that level? And that point is the anterior inferior angle of masseter muscle. Guys, masseter muscle is present somewhere here. In this region we have the masseter muscle. So this anterior inferior angle of masseter, let me point it out. That anterior inferior angle of masseter muscle, anterior inferior angle of masseter muscle, it pierces the deep cervical fascia. Now facial artery, as we said, it pierces the deep cervical fascia and appears on the face. So we have two parts of this facial artery. One is the cervical part, and then we have the facial part. The cervical part of the facial artery gives off four important branches. This is a schematic diagram, so I am not drawing exactly along their direction. So the four branches, in the cervical course, we can remember them as stag. Cervical branches, you can remember with the mnemonic stag, S-T-A-G. S is submental artery, T is tonsillar artery, A is ascending palatine. Remember the ascending palatine artery which we saw between the base of skull and superior constrictor, and G is glandular artery, the one which supplies submandibular gland. Submantle, tonsillar, ascending palatine and glandular, these are the cervical branches of facial artery, the stag. The named facial branches of facial artery are one to the lower lip, to the upper lip, to the ala of the nose and medial angle of eye. Now these are the facial branches. The facial branches we have inferior labial, superior labial, lateral nasal, and angular artery. All these branches are facial branches. All these branches are facial branches. Those are cervical branches, 4 cervical branches, and we have named 4 facial branches: inferior labial, superior labial to the upper lip, lateral nasal to the ala of the nose, and angular artery. And please note that this angular artery at the medial angle of the eye, it anastomoses with this artery called as dorsal nasal artery. It anastomoses with the dorsal nasal artery. The dorsal nasal artery is a branch of ophthalmic, and ophthalmic is a branch of internal carotid. Dorsal nasal artery is a branch of ophthalmic. Ophthalmic artery from inside the eye, there is only one artery, that is ophthalmic artery, or the branch of ophthalmic artery. Dorsal nasal artery is a branch of ophthalmic, and ophthalmic is a branch of internal carotid artery. So guys, we have this internal carotid artery and we have this external carotid artery. They both are anastomosing at the medial angle of eye. So please note that the medial angle of eye, this is the site for anastomosis of ICA and ECA. This is site of anastomosis for ICA and ECA, internal carotid artery and external carotid artery. So this is the site of anastomosis between ICA and ECA. So facial artery, we have all these facial branches on the face, named facial branches. We have unnamed branches which are going to the muscles. These are the named facial branches. Then we have the stag, the 4 branches which are given off in the neck, called the cervical branches of facial artery. Important thing is at what level it comes onto the face. It pierces the deep cervical fascia at the level of anterior inferior angle of masseter, and when it pierces the deep cervical fascia at the anterior inferior angle of masseter, we can also feel the pulsation of facial artery here. There is no deep fascia here, so we can feel the pulsation of facial artery at the anterior inferior angle of masseter, and that's why facial artery is also referred as the anesthetist's artery. It is also referred as the anesthetist's artery. You can feel the pulsation at the anterior inferior angle, so we call it anesthetist's artery. So guys, this is about the facial artery. Let's take a small break now, and when we'll come back from the break, we'll talk about the facial vein, venous drainage of the face, the temporomandibular joint, and also about the subclavian artery, and after that we will begin with the neuro. So let's take a break of 15 minutes or so and we'll catch back.